adjust the dosage. Some of the research that's out there for MBBS, they're doing 1 to 5 minutes of optokinetic stimulation, but some of the patients that I see with concussion would probably throw them for a loop. They're not going to be feeling so great. So we don't want to do that. We don't want to take the research from MBBS and just take it and plug it into these patients with concussion that have smeared maps. They might have dystonia. The follicular mapping is skewed. So I always like to start small. You might only want to just go 5 seconds, 10 seconds. Start with a small field. Maybe you just go with your hands. Maybe just have them close their eyes and start with their head. Progress to eyes open. Go in phase with it first, and then do something where you're going opposite. So you do have to be very careful. So you're going to want to look at the recovery after you do the optokinetic stimulation, and what's the appropriate dosage. Whatever you think is most appropriate based off of your examination for the person in front of you. It's going to be different with each person. So is the recovery slow or fast? If they have a slow recovery, then you probably want to do something to stabilize their autonomic system. Maybe you do vagal nerve stimulation. Maybe you do trigeminal stimulation. Activate the brainstem, cause some stability before you go into doing your therapies. Maybe you want to do more somatosensory information. And then from there, move into more real-world situations. Get the patient back driving, get them skating, get them back out on the ice, get them turning, give them specific direction of what motion and movements you want them to do. A lot of different programs will give people like, hey, you need to go out there, you need to watch these videos of this optokinetic. We want you to go out there and watch all these videos at the grocery store. We want you to watch these videos for 3 to 5 minutes. They don't give them good directions usually. We want you to just watch all these videos of optokinetic stimulation, and the person usually goes, if they're fragile, which is the people I see. I hated that. That's why they do that to me. I'm going to poop my pants now, So, what we don't want to do is that. We want to be specific, we want to be accurate, we want to stabilize their specific vestibular findings, and then we want to progress and then we want to move them into things that they can handle. Once you move them into things they can handle, it's kind of nice to start adding virtual reality optokinetic rehabilitation, and we'll talk about something called stationary anchoring, which is a technique that I started doing about 2 years ago. What's stationary anchoring? It's doing a small field optokinetic close to the patient with a background that has stationary anchors to give them a perception of steadiness while you're doing it in the foreground. Typical vestibular rehabilitation is going to do gaze stability in the foreground with a complex movement going on in the background.